Neurology, IM gait disorders. Cerebellar, due to lesion of vermis, truncal ataxia, or the cerebellar hemispheres, limb ataxia, cerebellar degeneration, common among chronic alcohol abusers, SX, gait instability, truncal ataxia, nystagmus. Intention tremor and hypotonia. PE, pendular knee reflex, persistent swinging movements of the limb after eliciting the DTR. QID, 4618, swaying from side to side, impaired tandem gait and titubation, truncal tremor, forward and backward movement of trunk, ipsilateral ataxia ESP. If tumor is located within one hemisphere, rightward arrow fall towards side of lesion even with eyes open. Other features: intention tremor, ipsilateral muscular hypotonia, and marked difficulty in coordination and performing rapid, alternating movements. Obstruction of CSF flow by tumor, rightward arrow, upward arrow, ICP, rightward arrow, headache, papilledema, nausea, and vomiting. Gait apraxia, Brunn's ataxia, due to damage of cortical fibers as in NPH, slow, broad, based shuffling gait, strength, coordination, and sensory functions are intact. Memory loss is very slow and progressive, DX, clinically or radionuclide CSF studies. MRI or CT shows dilated ventricles, due to downward arrow CSF absorption. Opening pressure NL, if symptoms improve on repeated large volume LP, spinal tap, then ventriculoperitoneal shunts can be considered definitive treatment. Step page gait, can be due to L5 radiculopathy or common peroneal nerve neuropathy. L5 radiculopathy, back pain radiating to foot, often weakness of foot inversion and plantar flexion. Common peroneal nerve neuropathy, due to compression of nerve on lateral aspect of fibula, e.g. due to prolonged crossing of legs or squatting, associated with paresthesia and sensory loss over dorsum of foot but normal foot inversion and plantar flexion, DX, clarified by EMG and nerve conduction studies. Spastic ataxia, pyramidal tract or corticospinal tract, CST, lesions can cause spastic ataxia. The gait appears stiff or rigid with circumduction, the spastic leg is abducted and advanced while in extension and internal rotation, and plantar flexion of the affected limb. Sensory neuropathy, patients with loss of proprioception due to sensory neuronopathy may have postural or gait instability and a wide-based gait. Patients may stomp their feet against the floor, slap gait, to help them know where their lower limbs are relative to the ground. Altered mental status. Hypernatremia BP/=180/120 mmHg, altered mental status. Rightward arrow suggest widespread dysfunction of cerebral cortex and or reticular activating system. When the cause of AMS is not apparent after initial assessment, empiric treatment for likely causes, e.g., WE, is often appropriate. Difference between upper and lower motor neuron lesion. Cranial nerves lesions. Facial nerve injury. Bell's palsy, acute peripheral neuropathy of CN7, lesion below the pons I.E. Below facial nucleus, in addition to above findings, may also downward arrow tearing, hyperacusis, and or loss of taste sensation over anterior 2/3 of tongue. Acute onset of symptoms, == 2 days, maximum clinical paralysis apparent within 3 weeks. For most PTS, partial or complete recovery occurs within 6 months. Forehead muscle sparing. Rightward arrow indicative of intracranial lesion. Rightward arrow brain imaging to evaluate ischemia or tumor, lesions in the central nervous system occurring above the facial nucleus, i.e., above the pons, can result in contralateral hemianesthesia or hemiparesis, and dysarthria. Upper facial weakness can occur with central lesions, however these lesions must occur at the level of the facial nucleus or exit of the fascicle of the facial nerve at the pontomedullary junction. Patients with Bell's palsy present with acute onset of symptoms, greater than or equal to 2 days, with maximum clinical paralysis apparent within 3 weeks. For most patients, Partial or complete recovery occurs within 6 months. Spinal cord lesions. Major fiber tracts of spinal cord. Lesion of corticospinal tract or UMN lesion, pronator drift. Physical exam finding sensitive and specific for pyramidal/corticospinal tract or UMN lesion, useful in PTS with subtle deficits as it can accentuate pyramidal motor weakness. Outstretch arms with palms upwards and eyes closed, so that only proprioception is used to maintain arm position. UMN lesion causes more weakness in supinator than pronator muscles of upper limbs. Rightward arrow, arm drifts downwards and palm turns, pronates, towards the floor. Clasp knife rigidity, velocity dependent resistance to passive movement of limb. Test for proprioception defect. Proprioception is evaluated by passively moving the distal phalange of a digit up and down and having patients identify the direction of movement with their eyes closed. Also assessed with the Romberg test, in which patients are observed for unsteadiness as they stand with their feet together, arms to the sides, and eyes closed. Patients with impaired proprioception, e.g., vitamin B deficiency, tabs dorsalis, have difficulty determining joint position and may lose balance during Romberg testing. Spinal cord compression. Renal. Spinal shock, gait ataxia, injury to descending autonomics in reticulospinal tract, urinary retention/bladder flaccidity/bladder shock, bowel/bladder disturbance are late findings. Thoracic spine is most frequently involved, level 60%, followed by lumbar spine. Pain is usually worse in the recumbent position, due to distension of the epidural venous plexus when lying down, in contrast to back pain from degenerative joint disease, which improves with recumbency. Urgent surgical intervention is necessary to prevent permanent disability. Central cord syndrome, CCS, occur with hyperextension injuries in elderly PT with pre-existing degenerative changes in cervical spine, causes damage to central portion of anterior spinal cord, specifically central portion of corticospinal tracts and decussating fibers of lateral spinothalamic tract, weakness more in upper extremities than lower as motor fibers serving arms are closer to the central part of corticospinal tract, may have occasional selective loss of pain and temperature sensation due to damage to spinothalamic tract. Anterior cord syndrome. B/L spastic paresis, initially flaccid paralysis due to spinal shock, usually due to occlusion of anterior spinal artery. ASA supplies anterior 2/3 of spinal cord, aortic surgery or dissection commonly associated with burst fracture of vertebra. ASA depends on blood supply from radicular arteries that originate from thoracic aorta, such as artery of Adamkiewicz, disruption of intermediolateral column and its descending autonomic tracts. Rightward arrow, autonomic dysfunction, bowel and bladder dysfunction, e.g. urinary retention. MRI is the best test to study extent of neurologic damage. Posterior, dorsal, cord syndrome, B/L loss of vibration and proprioception, often with weakness, paresthesias, and urinary incontinence or retention. Retention, due to multiple causes, multiple sclerosis, and vascular disruption, e.g. vertebral artery dissection, are most common. Brown-Séquard syndrome. 2. Levels below the level of lesion, cauda equina and conus medullaris syndrome. Cauda equina syndrome, due to compression of spinal nerve roots by disc herniation or rupture, tumor, spinal stenosis, infection, hemorrhage, or iatrogenic injury, spinal cord ends at level of L1, L2 and lumbosacral nerve roots below this level form cauda equine, which float in CSF. Cauda equine provides sensory innervation to saddle area, motor innervation to sphincters, anal and urethral, and parasympathetic innervation to bladder and lower bowel. Rightward arrow, lower motor neuron signs, in contrast conus medullaris. Rightward arrow, both UMN and LMN signs, management, emergency MRI, neurosurgical evaluation, and possibly 4 glucocorticoids, same management for conus medullaris syndrome, amyotrophic lateral sclerosis, neurodegenerative disease, signs of UMN and LMN degeneration. RX, riluzole glutamate inhibitor rightward arrow does not arrest underlying pathological process, may prolong survival and time to tracheostomy rightward arrow S/E, dizziness, nausea, weight loss, elevated liver enzymes and skeletal weakness. Tabes dorsalis. Brief, shooting or burning pain in face, back or extremities. Posterior spinal column, impaired vibration and proprioception, sensory ataxia, walks with legs wide apart, feet are lifted higher than usual and slapping sound comes when feet come in contact with ground, and instability during Romberg test, dorsal sensory roots, impaired pain and temperature and downward arrow/absent DTRs, Argyll-Robertson pupil, miotic, irregular, normal pupillary constriction with accommodation but not with light, Rx, 4 penicillin for 10 to 14 days. Subacute combined degeneration, vitamin B12 deficiency. Progressive symmetric polyneuropathy, more in legs than arms, dorsal spinal column, numbness/paresthesia, impaired proprioception/vibration and consequent gait ataxia, rightward arrow corticospinal tract, spastic weakness and hyperreflexia. Other consequences, peripheral neuropathy, memory loss and dementia. Labs, CBC, vitamin B12 levels, serum methylmalonic acid, more sensitive than vitamin levels. Brainstem lesions. Lateral mid-pontine lesions. Lateral mid-pontine lesions affect the motor and principal sensory nuclei. Nuclei of the ipsilateral trigeminal nerve, causing weakness of the muscles of mastication, diminished jaw jerk reflex, and impaired tactile and position sensation over the face. Medial mid-pontine lesions. Medial mid-pontine infarction presents with contralateral ataxia and hemiparesis of the face, trunk, and limbs, i.e., ataxic hemiparesis. There is also variable loss of contralateral tactile and position sense. Lateral medullary syndrome, Wallenberg syndrome, due to occlusion or dissection of intracranial vertebral artery or pica. Signs of nucleus ambiguous are typical loss of gag reflex, voluntary motor function of face and body usually intact, DX, made by MRI, RX, 4 thrombolytics, e.g. TPA. Medial medullary syndrome, alternating hypoglossal hemiplegia, due to branch occlusion of vertebral or anterior spinal artery present at the same time. Brain lesions. Posterior cerebral artery homonymous hemianopia, alexia without agraphia stroke, dominant hemisphere, visual hallucinations, calcarine cortex, sensory symptoms, thalamus, third nerve palsy with paresis of vertical and horizontal eye movements, and contralateral motor deficits, cerebral peduncle, midbrain. Urinary incontinence from damage to cortical micturition centers of mesial frontal lobe. Primitive reflexes may also appear like Moro, grasp and tonic neck reflexes. Aphasia. Dominant temporal lobe posterior inferior frontal gyrus supplied by MCA superior temporal gyrus. Check the table attached on page 460 of FA. Frontal lobe lesions dominant, as above. Non-dominant, contralateral apraxia due to involvement of supplementary motor cortex and conjugate gaze deviation to the side of lesion, contraversive frontal eye field, inability to speak nouns, anomic aphasia, visual field defect due to inferior optic radiations, Meyer's loop. Affect the way a person conveys emotion through speech, motor apraxia, contralateral weakness and apraxia. Parietal lobe lesions dominant, can present with contralateral sensory loss, e.g., pain, vibration, agraphesthesia, asteriognosis, and contralateral inferior homonymous quadrant anopsia due to superior optic radiations involvement. Non-dominant, right, responsible for spatial organization, neglect syndrome, PT neglects left side of body, typically cause anosognosia, denial of one's disabilities, and contralateral apraxia, inability to carry out learned purposeful movements. Temporal lobe lesions dominant, as above. Non-dominant, can impair ability to comprehend emotional gestures, sensory aprosodia. These patients can also develop a contralateral homonymous quadrant anopsia due to the inferior optic radiation's involvement. Cerebellar dysfunction, progressive gait dysfunction, truncal ataxia, nystagmus, intention tremor or dysmetria, limb, kinetic tremor when attempting to touch a target, and impaired rapid alternating movements, dysdiadochokinesia. Muscle hypotonia can also be present, leading to a pendular knee reflex, persistent swinging movements of the limb after eliciting the deep, tendon reflex. More than 4 swings is considered abnormal. Pendular reflexes are not brisk, unlike clonus, which would suggest pyramidal tract disease. Pyramidal tract signs, such as pronator drift, focal weakness, spasticity, hyperreflexia, and Babinski sign, are not observed with cerebellar lesions. Lacunar stroke. Underlying pathology is a combination of both, ultimately leading to thrombotic small vessel occlusion. Due to their small size, lacunes are often not appreciated on non-contrast CT obtained shortly after the event, commonly occur in internal capsule. Rightward arrow can cause pure motor hemiparesis, corticospinal and corticobulbar fibers, of contralateral arm, leg, and face. Lacunar stroke of thalamus lateral posteromedial thalamus typically occurs due to atherothrombotic occlusion of the small, penetrating, thalomogeniculate, branches of the posterior cerebral artery. Ventral posterolateral and ventral posteromedial nuclei of the thalamus transmit sensory information from the contralateral side of the body and face, respectively. Thalamic stroke in this region. Rightward arrow sudden, onset contralateral sensory loss involving all sensory modalities, i.e., pure sensory stroke. Symptoms can be accompanied by transient hemiparesis, athetosis, or ballistic movements due to disruption of neighboring basal ganglia structures and corticospinal fibers in the posterior limb of the internal capsule. Several weeks to months following the stroke, sensory deficits can improve. However, some patients develop thalamic pain syndrome, Dehaerine-Rousey syndrome. This condition is characterized by severe paroxysmal burning pain over the affected area and is classically exacerbated by light touch, allodynia. Lateral geniculate body. The lateral geniculate nucleus is located in the thalamus and relays visual information to the ipsilateral primary visual cortex. Damage to this structure would result in a contralateral homonymous hemianopsia. Arterial dissection commonly affects vertebral or internal carotid artery. Rightward arrow cause cerebral ischemia due to thromboembolism or hypoperfusion, neurologic deficits preceded by head or neck pain. Carotid dissection commonly causes partial ipsilateral Horner syndrome. Syndrome, ptosis and meiosis without anhidrosis, due to damage of postganglionic sympathetic fibers supplying the head. Vertebral artery dissection, lateral medullary syndrome, or Wallenberg syndrome, e.g., vertigo, ipsilateral ataxia, due to damage of vestibular nuclei and the inferior cerebellar peduncle. Types of cranial hematomos. Epidural hematoma. Failure to treat EDH emergently. Rightward arrow worsening intracranial hypertension and uncal herniation. On examination, patients with uncal herniation have dilation of the pupil on the ipsilateral side of the lesion, due to oculomotor nerve compression, along with ipsilateral hemiparesis, due to contralateral crus cerebri compression. Emergent craniotomy should be performed in patients with focal neurologic deficits to prevent brain herniation and death. Subdural hematoma. Small asymptomatic hematomas are managed conservatively. Diffuse axonal injury, most significant cause of morbidity in patients with traumatic brain injuries. It is frequently due to traumatic acceleration, deceleration injury and results in vegetative state. Sudden acceleration, deceleration impact produces rotational forces that affect the brain areas where the density difference is the maximum, thus most of the diffuse axonal injury occur at gray-white matter junction. C/F, out of proportion with the CT scan findings. Patient loses consciousness instantaneously and later develops persistent vegetative state. CT scan characteristically shows numerous minute punctate hemorrhages. Hemorrhages with blurring of gray-white interface. However, MRI is more sensitive than CT scan for diagnosing diffuse axonal injury. Major herniations of brain. Transtentorial, uncal, herniation. Post-concussive syndrome, traumatic brain injury, TBI, of any severity can lead to, a few hours or days later, post-concussive syndrome. SX, headache, confusion, amnesia, difficulty concentrating or with multitasking, vertigo, mood alteration, sleep disturbance, and anxiety. Typically, these symptoms resolve with symptomatic treatment within a few weeks to months following TBI. However, some patients may have persistent symptoms lasting / 6 months. Amaurosis fugax, sudden, painless loss of vision from emboli, cholesterol particles, Holland-Horst bodies, may be seen in eye. It is warning sign of impending stroke. Underlying embolic disease is almost always present. Most emboli occur from carotid bifurcation, hence, duplex USG of neck often done to identify any plagues which may be present. Major stroke subtypes. Usually lack of headache and impaired consciousness more common than AV malformation. HTN is the most important risk factor for stroke than any other risk factor. Hypertensive PTS have 4 times risk of stroke than non-hypertensive PTS. Ischemic stroke. Criteria for giving thrombolysis, for alteplase. Blood pressure control is critical in patients undergoing fibrinolytic therapy, and should be kept below 185/110 during in the 24 hours after it is administered. Labetalol, an alpha, 1 and beta adrenergic blocker, may be used for this purpose. In patients who do receive fibrinolytic therapy, aspirin should be held for 24 hours. Aspirin, only antiplatelet agent that is effective in reducing the risk of early recurrence of ischemic stroke and given to those who are not candidates for fibrinolytic therapy, should be given as early as possible, within 24 hours of stroke onset, and continue it indefinitely to prevent future strokes. Clopidogrel, given to those who fail or intolerant to aspirin. Long-term anticoagulation for stroke prevention. For stroke prevention in patients with atrial fibrillation based on the CHADS-2 criteria and stroke risk. Should be done with warfarin start 2 weeks after cardioembolic stroke to prevent recurrence. Heparin, avoid unfractionated and LMWH in acute stroke due to risk of bleeding. Intraparenchymal hemorrhage. HTN is more commonly associated with intracerebral or intraparenchymal hemorrhage than extraaxial hemorrhages. Amyloid angiopathy rightward arrow second most common cause of intracerebral hemorrhage rightward arrow typically lobar. AV malformation rightward arrow can cause both intracerebral or SAH but aneurysm is more common cause of SAH. AVM is most common cause of intraparenchymal hemorrhage in children. Venous sinus thrombosis rightward arrow intracerebral/intraparenchymal hemorrhages along the courses of major cerebral draining veins due to backup pressure. Progressively worsening headache over several days, common sites and presentation. Putamen. Early DX with non-contrast CT is crucial as early surgical decompression is life-saving due to reticular activating system disruption corticospinal and corticobulbar tract. Decerebrate rigidity descending sympathetic tract, usually occur during routine activities but may be precipitated by exertion. Hypertensive hemorrhages rightward arrow usually involve same small, penetrating arteries that cause lacunar stroke, frequently involved locations in table. Chronic HTN rightward arrow Charcot-Bouchard aneurysm rightward arrow rupture. Putaminal hemorrhage, almost always involve adjacent internal capsule rightward arrow cause of contralateral hemiparesis and hemisensory loss, due to disruption of corticospinal and somatosensory fibers in posterior limb of internal capsule, conjugate gaze deviation towards side of lesion, due to damage of frontal eye field efferents in anterior limb, I.E. Away from the paralytic side, may lead to stupor and coma, supplied by lenticulostriate arteries, small vessel branches from MCA. Lobar hemorrhages. Lobar hemorrhages typically occur in adults age 60 due to amyloid angiopathy. Hemorrhage tends to be recurrent and most often involves the occipital or parietal lobes. Occipital lobe hemorrhage may cause homonymous hemianopsia, whereas parietal hemorrhage can cause contralateral hemisensory loss. Subarachnoid hemorrhage. Cisterns are subarachnoid spaces that fill with blood in SAH, aneurysms 3 to 4% in general population but rarely rupture, more commonly rupture when 7 mm. Occur more in anterior circulation of circle of Willis, DX, CT without contrast rightward arrow negative rightward arrow LP upward arrow opening pressure and unexplained xanthochromia highly suggestive of SAH, further evaluation in SAH, cerebral angiography and treated with surgery, craniotomy with aneurysm clipping, or endovascular methods, coiling and / or stenting of the aneurysm. ESP. First 6 hours of untreated SAH from 3 to 10 days CT angiography preferred for detecting vasospasm occurs cause of narrowing of arteries at base of brain due to degradation of blood and its metabolites. Headaches cluster headache, U/L retro, orbital pain and later spreads to hemicranium, occurs in clusters, sudden onset usually night, peaks rapidly, lasts for approximate 2 hours daily, for 6 to 8 weeks and followed by remission up to a year. Associated with redness of eye, tearing, stuffed or runny nose, and ipsilateral Horner's syndrome, the pathophysiology is related to alterations in the circadian pacemaker, which may be due to hypothalamic dysfunction, short but severe attacks, hence, prophylaxis is key to management. Prophylaxis, verapamil, lithium, used for chronic form of cluster headaches, ergotamine, prednisone, methotrexate, cyproheptadine, and indomethacin. Rx acute attack, inhalation of 100% oxygen and subcutaneous or nasal sumatriptan migraine headache, Rx of acute migraine headache in children 12 years, migraine can be bifrontal and of short duration in children as compared to adults. Rx is mainly supportive, E.G. Lying in dark, quiet room. With cool cloth on forehead, and acetaminophen or NSAIDs like ibuprofen rightward arrow if not effective, oral, intranasal, or 4-triptans can be tried. Rx of acute migraine headache in adults, 4 antiemetics, chlorpromazine, prochlorperazine, or metoclopramide, can be used as monotherapy or as adjuvant therapy in combination with NSAIDs or triptan antiemetics given because of high tendency of vomiting. Triptan medications are an effective migraine treatment, but must be started early on in the course of the migraine before symptoms become severe in order to be of benefit. Prophylaxis, tricyclic antidepressants, E.G. Amitriptyline, propranolol intracranial hypertension, skull contains, brain parenchyma, CSF, and blood, upward arrow in any of these leads to itch. Causes, tumor, trauma, hydrocephalus, impaired CNS venous flow, and idiopathic, IIH, C/F, headache, worse at night, N/V, and mental status changes, E.G. Downward arrow level of consciousness, cognitive dysfunction. Focal neurologic symptoms, E.G. Vision changes, unsteady gait, and seizures may also be present. SX can worsen with maneuvers that upward arrow intracranial pressure like bending forward, Valsalva, coughing etc., sign, papilledema and focal neurologic deficits. Cushing reflex, HTN, bradycardia, respiratory depression, worrisome findings suggestive of brainstem compression and upward arrow intracranial pressure. Interventions for lowering intracranial pressure: idiopathic intracranial HTN, IIH, or pseudotumor cerebri. Isotretinoin, growth hormone, OCPs, glucocorticoids. Holocranial headache worse with lying flat and improves with standing, visual changes like blurry vision, Diplopia papilledema can lead to momentary vision loss that varies according to changes in head position. Rightward arrow urgent DX rightward arrow if persistent rightward arrow permanent vision loss to rule out cerebral venous thrombosis, pathology, impaired absorption of CSF by arachnoid villi or upward arrow production slit-like appearance of lateral ventricles, pain usually worse at night or lying flat. Pain associated with upward arrow ICP is usually worse in the morning. QID 4900, empty cella present in 70% PTS but is non-diagnostic. RX goals: prevent vision loss, downward arrow ICP, and symptomatic relief of headache, fundoscopy and routine monitoring of visual acuity and visual fields to prevent vision loss. RX: acetazolamide rightward arrow first line rightward arrow inhibit choroid plexus carbonic anhydrase rightward arrow downward arrow CSF and IH. Add furosemide in PTS with continued symptoms rightward arrow symptoms refractory to medical therapy or those with progressive vision loss rightward arrow surgical intervention with optic nerve sheath decompression or lumboperitoneal shunting is recommended. Short-term use of corticosteroids or serial lumbar puncture, LP, can serve as bridging therapy for patients awaiting definitive surgical treatment. Rightward arrow not recommended as primary intervention due to side effects. Papilledema is not CI for LP unless there is evidence of non-communicating hydrocephalus, and/or space-occupying lesion with/without mass effect or midline shift performed in lateral decubitus position with legs extended. Cavernous sinus thrombosis, CST, it can be caused by infection, because the facial/ophthalmic venous system is valveless. Uncontrolled infection of the skin, sinuses, and orbit. Rightward arrow spread to the cavernous sinus. Rightward arrow inflammation of the cavernous sinus. Rightward arrow life-threatening CST and intracranial hypertension, itch. C/F, headache most common symptom and can become intolerable. A low-grade fever and periorbital edema usually occur several days later secondary to impaired venous flow in the orbital veins. Itch rightward arrow vomiting and papilledema on fundoscopy. Cranial nerves 3, 4, V, and 6 pass through the cavernous sinus, which has anastomosis crossing midline. As a result, unilateral symptoms, e.g., headache, binocular palsies, periorbital edema, hypoesthesia, or hyperesthesia in V1/V2 distribution, can rapidly become bilateral. DX, magnetic resonance imaging with magnetic resonance venography is the imaging modality of choice for diagnosis of CST. RX, broad spectrum intravenous antibiotics and prevention or reversal of cerebral herniation. The valveless venous system, cerebral edema, mannitol rightward arrow downward arrow ICP associated with cerebral edema. Given for and needs regular monitoring of renal function and electrolytes. Rightward arrow used in inpatient setting in PTS with severely elevated ICP, obtunded PTS, warfarin-associated intracerebral bleed. OTC cold meds usually contain acetaminophen. Rightward arrow potentiate anticoagulant effect of warfarin. Also contains decongestants. Rightward arrow upward arrow BP. Severe cough. Rightward arrow upward arrow intracranial pressure. Rightward arrow upward arrow risk of intracerebral hemorrhage, RX, reverse anticoagulation immediately. Rightward arrow vitamin K and prothrombin complex concentrate are given. If PCC not available, rightward arrow give FFP. Vitamin K. Rightward arrow sustained effect over 12 to 24 hours. PCC rightward arrow contains vitamin K dependent clotting factors, 2, 7, 9, X. Rightward arrow provide rapid but short-term reversal of symptoms. FFP takes longer to prepare/administer and require more volume infusion compared to PCC. Torticollis, focal dystonia of sternocleidomastoid, can be congenital, idiopathic, 2* to trauma or local inflammation or drug-induced. Metoclopramide, atypical antipsychotics, prochlorperazine. Neuroleptic malignant syndrome. In contrast, hyperreflexia and myoclonus are typical of serotonin syndrome, rigidity in NMS. Rightward arrow muscle necrosis. Rightward arrow upward arrow CPK, leukocytosis and electrolyte abnormalities, begin within 2 weeks of initiation of causative drug. Rightward arrow mortality 10 to 20%, type of type B drug reaction, unexpected, dose independent, e.g. Stevens-Johnson syndrome with lamotrigine, type A drug reactions, dose, dependent increases in normal pharmacologic action, e.g. respiratory depression with opioids. Metoclopramide, induced dystonic reaction, dopamine antagonist, used to treat nausea, vomiting and gastroparesis, significant prokinetic effect. Rightward arrow promote peristalsis, upward arrow strength of gastric contractions, and relaxation of pyloric sphincter, S/E, agitation and loose stools. Extrapyramidal symptoms, tardive dyskinesia, dystonic reactions, and Parkinsonism, occur less frequently. Neuroleptic malignant syndrome may occur rarely, Rx of dystonic reaction, discontinuation of medication, and administration of benztropine, or diphenhydramine. Chemotherapy-induced peripheral neuropathy, causative agents, vinca alkaloids, E.G. Vincristine, platinum-based meds, E.G. Cisplatin, and taxanes, E.G. Paclitaxel, starts weeks after treatment initiation, C/F, symmetrical paresthesia in fingers and toes spreading proximally in stocking, glove pattern, early loss of ankle jerk reflex and loss of pain and temperature sensation. Occasionally there can motor neuropathy resulting in weakness and B/L foot drop. Stiff person syndrome, rare, autoimmune disorder, rigidity, stiffness, muscle spasms involving axial skeleton. Autonomic instability can occur but mental status changes are typically not seen. Paraneoplastic syndromes. Symmetric reflexes preserved. Myasthenia gravis. Can also cause symmetric proximal muscle weakness involving neck and upper extremities, E.G. difficulty holding neck and difficulty combing hair, C/F highly suggestive of MG. Positive ice pack test. Ice pack placed on eyes for several minutes improves symptoms. I.E. Cold temp inhibit breakdown of acetylcholine in NMJ. Rightward arrow perform acetylcholine receptor antibodies test. Rightward arrow negative. Rightward arrow check muscle, specific tyrosine kinase antibodies. Rightward arrow unclear diagnosis. Rightward arrow electrophysiologic studies, e.g. repetitive nerve stimulation, single fiber electromyography, may be helpful. Rightward arrow diagnosis established. Rightward arrow chest CT or MRI as thymectomy can lead to long-term improvement. Myasthenic crisis. Preferred over IVIG azithromycin given after PT is stabilized, following intubation. Acetylcholinesterase inhibitors, e.g. pyridostigmine, used in daily management of MG are temporarily held to reduce excess airway secretions and risk of aspiration. Other immunomodulatory therapy, e.g. mycophenolate mofetil or azathioprine, can be considered, especially if corticosteroid therapy is ineffective, but usually requires several weeks to reach clinical efficacy. Lambert-Eaton syndrome, downward arrow acetylcholine release from pre-synaptic terminal, approximate 50% cases have underlying malignancy, most common being small cell lung cancer. Examples, difficulty standing from chair, combing hair, placing dishes overhead. Vigorous activity can improve muscle strength and reflexes temporarily. DX, checking autoantibodies and electrophysiologic studies. RX, symptomatic therapy includes guanidine or 3,4-diaminopyridine to increase presynaptic acetylcholine levels. Refractory symptoms may respond to immunologic therapy with IVIG or oral immunosuppressants, E.G. Corticosteroids, azathioprine, multiple sclerosis. Electric shock, like sensation down the spine or limbs on flexion of neck. Gradual progression from initial onset without acute relapse. Steady deterioration after initial relapsing. Remitting stage. Progressive disease between relapses. Neuropsychiatric disturbance, hypo/hyperintense lesions are seen on MRI. Periventricular, juxtacortical, and infratentorial regions. Spinal cord may also be involved, IgM and IgA may also be increased. Immunoglobulins can be upward arrow-ed in other conditions like neuropathies, chronic CNS infection or viral syndromes rightward arrow, hence, oligoclonal bands are non-diagnostic. CSF, normal pressure, total cell count and total protein CONC. Predominant cell type, T lymphocytes, Rx. Acute relapse, high dose intravenous glucocorticoids, methylprednisolone. Corticotropin injection gel, a purified form of adrenocorticotrophic hormone, can be used as alternate therapy. Plasma exchange is also reserved for those who do not respond to high-dose glucocorticoids. Long-term disease-modifying therapy, glatiramer, interferon, mitoxantrone, cyclophosphamide, methotrexate, and cladribine. Differential diagnosis of flaccid paralysis plus respiratory support plus NG tube feeding infant botulism. Raw honey ingestion is also a risk factor. Highest incidence, California, Pennsylvania, and Utah. Greatest CONC of soil botulism spores, environmental dust, e.g. construction site, rightward arrow ingestion of spores rightward arrow C. Botulinum colonize : rightward arrow produce and release toxin rightward arrow block ACH release at presynaptic NMJ, suspect diagnosis, infants with bilateral bulbar palsies, e.g., ptosis, sluggish pupillary response to light, poor suck and gag reflexes, followed by symmetric descending flaccid paralysis, hypotonia. Constipation and drooling due to autonomic dysfunction also occur. Botulism immune globulin should be administered as soon as possible, even before diagnostic confirmation of stool spores or toxin. Foodborne botulism. Prodromal symptoms, GI discomfort, dry mouth, and sore throat for adults and children 1 year. This antitoxin is horse-derived. Supportive care is also needed. The presentation differs from infant botulism in that the descending flaccid paralysis is preceded by a prodrome of nausea, vomiting, abdominal pain, and diarrhea. Guillain-Barré syndrome. Albuminocytologic. Albuminocytologic dissociation. Both are equally effective and choice depends on specific risk factors and availability. The final stage is flaccid paralysis with absent deep tendon reflexes and nerve conduction velocities. Glucocorticoids are not beneficial, Campylobacter jejuni most frequently associated. Other organisms, herpes virus, mycoplasma, and H. influenza also associated. Recent HIV infection and recent immunization, more common in PTS with sarcoidosis, SLE, and lymphoma. Recovery follows the inverse order of the initial disease progression. Neuromuscular respiratory failure is the most life-threatening complication. Rightward arrow. Once DX of GBS confirmed, rightward arrow assess pulmonary function by serial spirometry. FVC is the gold standard for assessing ventilation. If 20 ml/kg rightward arrow indicate impending respiratory arrest, rightward arrow endotracheal intubation. If spirometry not readily available or difficult in unstable PT, rightward arrow peak flow meter is performed but less accurate. Tremors. Action or postural tremor, low frequency 3 to 4 Hz. Postural/action/intention tremor. Postural tremor, e.g. holding hand outstretched, infrequently occur with action. Essential tremors may follow autosomal dominant pattern of inheritance, may affect any part of body, can involve head, chin, voice, and tongue, ESP. Apparent when arms are out, stretched. Upward arrow in amplitude at very end of goal-directed activity, ESP. Fine motor movement can be present at rest as well. Rx, beta blocker propranolol, not given if PT is bradycardic or has severe COPD, or primidone or topiramate. Benzos can also downward arrow symptoms but avoid them, primidone, anticonvulsant medication. Converts into phenylethylmelanamide and phenobarbital. Rightward arrow S/E, may precipitate acute intermittent porphyria. Rightward arrow abdominal pain, neurologic and psychiatric abnormalities, confusion, headaches, hallucinations, dizziness, rightward arrow diagnosed by checking urine porphobilinogen orthostatic tremor, a postural tremor considered to be a variant of essential tremor. Orthostatic tremor occurs in the legs immediately on standing and is relieved by sitting down. It is usually high frequency, 14 to 18 Hz, without other clinical signs or symptoms. Parkinson's tremors. Resting tremors usually start in one hand and later in other hand rightward arrow rest of the body rightward arrow lower leg pill rolling 4 to 6 Hz. Can involve jaw, face, tongue, and lips. Associated with rigidity. Often presenting symptom of Parkinson disease, anticholinergics, e.g. benztropine, trihexyphenidyl, treatment of choice. Trihexyphenidyl typically used in younger PTS where tremor is predominant symptom. Huntington's chorea, haloperidol is used for Huntington's chorea. Huntington disease, autosomal dominant / CAG triplets repeat. Characterized by choreiform movements, cognitive decline, mood dysfunction. Number of CAG repeats may increase with subsequent generations, anticipation. Begins between ages 30 to 50, atrophy of the caudate nucleus is a characteristic feature. Chorea, sudden, jerky, and irregular movements of the extremities. Facial grimacing, ataxia, dystonia, tongue protrusion, writhing movements of extremities. Parkinson disease, presence of any two of these three suggest clinical diagnosis rightward arrow further. Confirm by physical exam. 1. Rigidity uniform rightward arrow lead pipe, or oscillating rightward arrow cogwheel. 2. Bradykinesia narrow, base, hypokinetic, shuffling gait, festinating gait, and 3. Tremor. Agitation, dizziness, nausea. These are initial symptoms. Involuntary movements, dystonia, dyskinesia, 10 years of therapy in 50% PTS. As a result, IMP. To find initial therapeutic dose and closely monitor PT, dyskinesia is earlier finding with COMT inhibitors. Anticholinergics do not improve bradykinesia but improves tremors and rigidity. Parkinson psychosis, UW, 12152, visual hallucinations and paranoid delusions. First step is anti-Parkinson medication adjustments. Rightward arrow fail. Rightward arrow anti-psychotic, quizapine, clozapine, or pimavanseran. Restless leg syndrome. Evaluation should include exclusion of secondary causes and diseases that may present similarly. PTS with comorbid insomnia, chronic pain syndrome or anxiety may benefit from alpha, 2, delta calcium channel ligands over dopaminergic agents. Rightward arrow gabapentin is similar to GABA but targets voltage-gated calcium channel. PTS with refractory symptoms after this treatment may benefit for opioids. Dementia, MMSE score 24 is suggestive of dementia. Maximum score is 30. By definition, social functioning must be impaired in order to diagnose dementia. Difference between dementia and normal aging. Expressive aphasia in normal adults is most likely because of some age-related impairment of dominant frontal lobe 1. MMSE normal equals greater than or equal to 24/30. Differential diagnosis of dementia subtypes 2. Montreal Cognitive Assessment normal equals greater than or equal to 26/30. Vascular dementia presents as a sudden or stepwise decline in executive function after stroke, which interferes with activities of daily living. Patients typically have abnormal neurologic findings on examination, e.g., hemiparesis, pronator drift, Romberg sign. Fecal incontinence may develop in advanced disease. Alzheimer's disease almost exclusively occurs in individuals over the age of 60. Associated risk factors include age, female gender, positive family history, head trauma, and Down syndrome. Later findings usually include personality and behavioral changes, e.g., apathy, agitation, confusion, disorientation, difficult to distinguish from pseudodementia, as depression can occur as comorbid condition. Selective loss of cholinergic neurons, findings suggestive of Alzheimer's, presence of more symptoms, such as apraxia, agnosia, aphasia, and disturbance in executive functioning, lifespan 3 to 8 years after diagnosis. CT scan to exclude other causes. Rightward arrow normal initially, rightward arrow later. Cortical and sub-cortical atrophy, only minimally more than normal controls of same age. Parietal and temporal lobes more commonly affected. ESP. Hippocampus, diagnosis, MMSE, neuropsychological testing, and following diagnostic criteria, 2 or more areas of cognitive deficits, progressively worsening memory and other cognitive function, no disturbance of consciousness, onset after age 60 and risk. Upward arrow ES with age, absence of other systemic or neurologic disorder causing progressive cognitive defects. RX, psychosocial intervention and pharmacological intervention. Acetylcholinesterase inhibitors, donepezil, Aricept, galantamine, rocidine, galantamine ER, rocidine ER, and rivastigmine, Exelon, for mild to moderate dementia. Improve quality of life and cognitive functions, including memory, language, thought, and reasoning. Donepezil is approved for all stages. N-methyl, D, aspartate receptor antagonist. I.E. Memantine, for moderate to severe dementia. Pix-de-C/fronto, temporal dementia, early onset 40 to 60 years. 40% have positive family history, similar to Alzheimer, but disease progression is different. Personality change, euphoria, disinhibition and apathy, loss of social restraints, compulsive behavior, e.g. peculiar eating habits, hyperality. Rightward arrow disorientation and memory loss. Rightward arrow mute, immobile, and incontinent. Visuo, spatial functions usually remain intact. CT, frontal and temporal lobes atrophy. Lewy body dementia, cause of 10 to 20% of dementias in the United States. Characterized by alterations in consciousness, disorganized speech, visual hallucinations, extrapyramidal symptoms, and relatively early compromise of executive functions. Visuospatial decline before memory deficits, opposite of AD. Prominent or persistent memory impairment may not occur early but usually evident with progression. Autopsy findings, Lewy bodies, or eosinophilic intracytoplasmic inclusions. Rightward arrow represent accumulations of alpha-synuclein protein seen in neurons of the substantia nigra, locus ceruleus, dorsal raphe, and substantia innominata. Treatment of motor and psychiatric symptoms, acetylcholinesterase inhibitors like rivastigmine. For hallucinations refractory to acetylcholinesterase inhibitors. Rightward arrow atypical anti-psychotics may benefit. Poor response to dopaminergic agonists and worsening of features with neuroleptic drugs. Lewy bodies are also present in Parkinson's disease. The key distinction between these two, early appearance of dementia in Lewy body disease and of motor symptoms in Parkinson's disease. With pronounced variation in attention and alertness, 2 of the core features are essential for probable diagnosis and 1 for possible diagnosis. Pseudodementia/reversible cognitive impairment. Elderly PT with major depression may present with pseudodementia. Dementia and pseudodementia may present similarly, and CT findings may be normal in Alzheimer's disease as well, although dementia will be associated with other findings too. No single test to distinguish between dementia and pseudodementia. However, dexamethasone suppression test, DST, is abnormal in 50% of pseudodementia PTS and may help physician to detect endogenous depression. Can also have slow movements due to psychomotor retardation. An interesting difference between pseudodementia and dementia of Alzheimer's origin is that patients with pseudodementia tend to be overly concerned about their memory loss and often seek help. On the other hand, patients with Alzheimer's tend to be indifferent to their memory loss and are usually brought in by their families. RX, Depressants rightward arrow improvement in depression but not cognitive symptoms rightward arrow consider Alzheimer and give Donepezil, acetylcholinesterase inhibitors, Creutzfeldt, Jakob disease, spongiform encephalopathy caused by prion, features other than table, insomnia, apathy, behavior abnormality, and sharp, bi, or tri-phasic, synchronous discharges on e.g. Ultimately, PT loses ability to speak and move and become comatose. Most PTs die within 1 year of onset of symptoms. Key features of this disease include a long incubation period, characteristic spongiform changes, and lack of inflammatory response. Most cases are sporadic, 85%, with the remainder being hereditary or iatrogenic, due to contaminated transplants or surgical instruments. Rx, supportive. Neurosyphilis. HIV, associated dementia had, untreated HIV patients with a CD4 plus cell count of 200 and in patients with long-standing HIV disease. 1. Onset is typically subacute and characterized by increasing apathy and impaired attention. 2. Subcortical SX, slowed movement and difficulty with smooth limb movement. Happens early in the disease. 3. Memory decline. Adherence to antiretroviral therapy decreases the chance of developing HAD, and resuming treatment may improve HAD symptoms. UW equals 11,954, neurosyphilis appears in 15 to 20% of late syphilis cases. There are 4 types. In general paresis type, there is general involvement of the cerebral cortex. There is usually a decrease in concentrating power, memory loss, dysarthria, tremors of fingers and lips, irritability, and mild headaches. In addition, there are also characteristic personality changes, with the patient becoming slovenly, irresponsible, confused and psychotic. Multiple system atrophy/SHI, Draeger syndrome, degenerative disease characterized by 1. Parkinsonism. 2. Autonomic dysfunction, postural hypotension, abnormal sweating e.g. dry skin, disturbance of bowel or bladder control, abnormal salivation or lacrimation e.g. dry eyes or dry mouth, impotence, gastroparesis, etc. 3. Widespread neurological signs, cerebellar, pyramidal, or lower motor neuron, accompanying bulbar dysfunction and laryngeal stridor may be fatal. Rx, anti-Parkinsonism drugs not effective. Treatment aimed at intravascular volume expansion with fludrocortisone, salt supplementation, alpha, adrenergic agonists and application of constrictive garments to lower body. Riley-Day syndrome or familial dysautonomia, autosomal, recessive disease seen predominantly in children of Ashkenazi Jewish ancestry. Characterized by gross dysfunction of the autonomic nervous system with severe orthostatic hypotension. Delirium. Waxing and waning levels of consciousness. Initial evaluation should include a focused history and physical evaluation, including pulse oximetry, review of all medications, complete blood count, serum electrolytes and urinalysis and possible imaging. Infection identified rightward arrow treat ASAP. Rx, regardless of cause, treatment of agitation in elderly, low-dose haloperidol. Atypical antipsychotics, risperidone, quizapine, may also be used. Usage of typical and atypical antipsychotics is safe in acute setting, but prolonged use upward arrow mortality in elderly. Typical antipsychotics should not be used in Lewy body dementia, who may exhibit neuroleptic hypersensitivity, severe Parkinsonism and impaired consciousness with neuroleptic administration. Heat stroke. Rhabdomyolysis. Rhabdomyolysis, as exists on the same spectrum as heat exhaustion with a body temperature 40 C, 104 F, but is characterized in addition by central nervous system, CNS, dysfunction, e.g., confusion, irritability, seizures. Main mechanism of heat dissipation, evaporation of sweat. If humidity 75% rightward arrow sweating overwhelmed rightward arrow exertional heat illness, other C/F, include dry or sweaty skin, hypotension, tachycardia, hyperventilation, diarrhea, cramps, and ataxia. Mortality rate 20% non-exertional or classic heat stroke, evaporative cooling, i.e., spraying the naked patient with lukewarm water and running fans to circulate air, is preferred for non-exertional or classic heat stroke, seen in elderly patients with underlying comorbidities that limit their ability to cope with excessive heat, as ice water immersion is associated with higher morbidity and mortality in these patients. Seizures and syncope. Work up for first-time seizure. Initial diagnostic evaluation of a first-time seizure in an adult is aimed at excluding metabolic, e.g. hypoglycemia, electrolyte disturbances, and toxic causes, amphetamine use and alcohol/benzo withdrawal. 1. Basic lab tests: serum electrolytes, glucose, calcium, magnesium, CBC, RFTs, LFTs, and toxicology screen. 2. ECG in PTS with LOC to rule out arrhythmia. 3. Imaging. Once metabolic and toxic causes ruled out, rightward arrow neuroimaging performed, e.g. brain MRI or CT without contrast in emergency situation, as it can be performed in unstable PT and needed to rule out intracranial bleed, and MRI in non-emergency and elective situations due to better visualization, to evaluate structural brain abnormalities, e.g. tumor, stroke, cerebral infarction, mesial temporal sclerosis, infections, cortical dysplasia, vascular malformations, traumatic brain injury. 4. Lumbar puncture after imaging has ruled out space-occupying lesion, reserved for suspected meningitis. 5. Routine EEG risk, stratifying patients after a first-time seizure once metabolic and toxic etiologies have been excluded. The presence of epileptiform activity on an EEG indicates a higher risk of seizure recurrence and therefore may justify the need to start anti-epileptic therapy. Status epilepticus. Definition: historical, a single seizure lasting 30 minutes latest, any single seizure lasting 5 minutes or a cluster of seizures with PT not recovering anormal. Mental status in between, occur in 30% PTS with epilepsy ESP. Those non-compliant with medication. Recent studies suggest that a brain that has seized for 5 minutes is at upward arrow risk of developing permanent injury to excitatory cytotoxicity. Cortical laminar necrosis is the hallmark of prolonged seizures and can lead to persistent neurologic deficits and recurrent seizures. MRI of the brain will generally show evidence of cortical hyperintensity on diffusion, weighted imaging suggesting infarction. Syncope. Trigeminal neuralgia, Tic-Douloureux, carbamazepine treatment of atypical bipolar depression and trigeminal neuralgia effective in 80% cases. S/E, aplastic anemia can occur with prolonged use, therefore, routine CBC is included in follow-up. If medication fails to control pain, rightward arrow surgical gangliolysis or suboccipital craniectomy for decompression of trigeminal nerve are options. Trigeminal neuralgia is characterized by recurrent and sudden onset severe stabbing pain along the V2 maxillary and V3 mandibular branches of the trigeminal nerve. Multiple sclerosis should be suspected when trigeminal neuralgia presents bilaterally. Carotidynia, neurological condition caused by inflammation of the carotids and the vagus. The pain is sharp and localized to the carotid artery distribution in the neck. Usually, the intensity of pain is much less. The diagnosis is clinical, although an MRI is sometimes required. Burning mouth syndrome, rare cause of facial pain. It is caused by a virus and the individual has reddened mucosa and has significant pain. The condition is aggravated by dryness. It is treated by supportive care. Brain abscess. 50% due to direct extension. Most common flora recovered, viridans, e.g. S. mitis, S. intermedius, S. oralis, S. mutans, and other anaerobes, e.g. Prevotella, Peptostreptococcus, Bacteroides. 25% result from hematogenous spread Gram-VE organisms and S. aureus are implicated. Rarely, due to direct inoculation from trauma or neurosurgery, S. aureus implicated for 8 weeks, classic triad of headache, focal neurologic deficit and fever. 20%. Fever is present in only 50% cases. Upward arrow ICP depicted by morning or nocturnal headache and vomiting is usually the most prominent sign. CT with contrast, superior for depicting bone, fast, or MRI, superior for soft tissue details, does not use ionizing radiations, more sensitive for early cerebritis and is better at delineating the extent of ring enhancement and differentiating between edema and necrosis, showing ring enhancing lesion. Uniform contrast enhancement is highly specific but should be confirmed by culture of aspirated or resected material. Spinal epidural abscess. CSF findings. Herpes encephalitis, most common cause of fatal sporadic encephalitis in U.S., beyond neonatal period. HSV-1 is the most common cause, C/F. It presents with acute onset, 1 WK duration, of focal neurological findings, altered mentation, focal cranial nerve deficits, ataxia, hyperreflexia, or focal seizures, fever in 90% PTS. Behavioral changes can be seen, and behavioral syndromes like hypomania, Kluver-Bucy syndrome, hyperphagia, hypersexuality, and amnesia have been reported. CSF findings, lymphocytic pleocytosis, upward arrow no. of RBCs, hemorrhagic destruction of temporal lobes. Upward arrow proteins, downward arrow glucose generally not seen. PCR analysis of HSV DNA in CSF, highly sensitive and specific, gold standard of diagnosis, replacing brain biopsy, brain imaging, temporal lobe lesions. MRI preferred over CT, which is normal in 50% cases. Focal EEG findings, prominent intermittent high amplitude slow waves in 70 to 80% cases and can be used in some cases as corroborative evidence, RX, for acyclovir treatment of choice. Tick-borne paralysis, progressive ascending paralysis over hours to days. May be localized or more pronounced in one leg or arm, fever typically not present. H/O fever or prodromal illness makes the diagnosis unlikely. Normal sensations, normal autonomic system, unlike Guillain-Barré syndrome, CSF normal. Etiology, tick needs 4 to 7 days for the release of neurotoxin. Rightward arrow paralysis, RX, meticulous search for tick usually reveals a tick. Rightward arrow removal leads to improvement within an hour and complete recovery after several days. Primary CNS lymphoma in HIV patient, altered mental status, EBV DNA in CSF and solitary weakly ring, enhancing periventricular mass on MRI, D/D, toxoplasmosis, multiple, ring, enhancing, spherical lesions in basal ganglia, uncommon in PT. Taking TMP, SMX. Positive serology is common in US and non-diagnostic acoustic neuroma, best diagnosed by MRI with gadolinium staining preferred over CT. Audiometry is the best initial screening laboratory test for acoustic neuroma, young age, multiple cafe, less spots, usually B/L. Rightward arrow neurofibromatosis type 2, usually U/L in sporadic cases but arises after 40 years. Neurofibromatosis type 2, autosomal dominant caused by a mutation in tumor suppressor gene on chromosome 22. Severe variant, Wishart caused by frame shift or nonsense mutation. Milder variant, Gardner result from splice site or missense mutation. CNS tumors, glioblastoma multiforme, personality change and strange behavior. Rightward arrow localizes lesion to frontal lobe, CT/MRI, butterfly lesion with central necrosis is classic and heterogeneous. Serpiginous contrast enhancement is typical of high-grade astrocytoma. Meningioma, benign primary brain tumor, common in middle-aged and elderly women, extra, axial, well, circumscribed, dural-based mass, round homogeneously enhancing on MRI usually undergo partial calcification, can cause focal neurologic symptoms, DX, confirmed intraoperatively, RX, complete surgical resection in symptomatic cases, rightward arrow cures in most cases. Focused tumor. Radiation, stereotactic radiosurgery, can be considered in partially resected or unresectable tumors. Cellular masses. Craniopharyngioma, arise from Rathke's pouch, 50% cases 20 years ESP. Between 55 to 65, grow gradually and can cause slowly progressive symptoms, DX, CT or MRI, RX, surgery and/or radiation. Metastatic brain tumor, most common type of intracranial brain tumor, can be solitary or multiple, location, usually gray, white matter junction, frequently seen in PTS with non-small cell lung cancer, NSCLC, approximate 80% metastatic brain tumors are lung cancers. Favorable survival outcomes after diagnosis of brain mets, age 65, good functional performance, and stable extracranial disease. Aggressive treatment is generally required to improve survival and control CNS disease. Single brain metastasis in surgically accessible location and good performance status. Rightward arrow surgical resection is best therapeutic option. This is typically followed by stereotactic radiosurgery, SRS, or whole brain radiation therapy, WBRT, to tumor bed. PTS who are not surgical candidates, have surgically inaccessible lesion or smaller mets, 3 cm, rightward arrow SRS, multiple brain mets or poor performance status. Rightward arrow WBRT or supportive care is typically recommended. Brachytherapy, implantation of a radioactive source directly into an intracerebral mass or surgical cavity, allowing higher radiation doses to be delivered directly into the brain without affecting other organs. It is typically used in conjunction with surgery, or after recurrence following WBRT or surgery. Chemotherapy might be used in case of brain metastasis from chemosensitive tumors, e.g., small cell lung cancer, lymphoma, choriocarcinoma. Visual field defects. Internuclear ophthalmoplegia, a disorder of conjugate horizontal gaze in which the affected eye, ipsilateral to the lesion, is unable to adduct and the contralateral eye abducts with nystagmus. Convergence and the pupillary light reflex are preserved. Internuclear ophthalmoplegia results from damage to the heavily myelinated fibers of the medial longitudinal fasciculus, MLF. The MLF is a paired neural tract that mediates communication between CN3, oculomotor, and CN6, abducens, nuclei, allowing for coordinated horizontal eye movements. Unilateral MLF lesions can occur with lacunar stroke in the pontine artery distribution. Bilateral lesions are classically seen in multiple sclerosis. Edinger-Westphal nucleus injury. The Edinger-Westphal nucleus provides preganglionic parasympathetic outflow to the eye. Damage to this structure would result in an ipsilateral fixed and dilated pupil that is non-reactive to light or accommodation. Cranial nerve 3, oculomotor nerve, neuropathy. Somatic and parasympathetic fibers of CN3 have different nerve supplies. Can be due to ischemia or compression. Ischemic neuropathy occurs in diabetes, only affects somatic fibers. Rightward arrow ptosis, down and out gaze. Accommodation and pupil's response to light remains intact. Compression neuropathy, due to transtentorial, uncal, herniation or aneurysm of posterior communicating artery, both somatic and parasympathetic fibers affected. Rightward arrow ptosis, down and out gaze and fixed, dilated pupil and no accommodation reflex. Cranial nerve 4, trochlear, neuropathy, traumatic or idiopathic, presents with vertical diplopia that worsens when the affected eye looks down and toward the nose, e.g., walking downstairs, reading. Patients may compensate by tucking the chin and tilting the head away from the affected eye. Corneal abrasion. Indications for ophthalmology referral include ulceration, pus, drop in visual acuity, the potential cause of blurry vision in this patient, or lack of healing within 3 to 4 days. Acute angle closure glaucoma, usually occur in individuals 60 years, due to sudden narrowing or closure of anterior chamber angle. In PTS with AC, lens is located more forward and rests against the iris. Rightward arrow partially covers anterior chamber angle and prevent normal flow of aqueous humor, through pupil and into anterior chamber. Rightward arrow upward arrow intraocular pressure, causes of acute AC, sudden angle closure in response pupillary dilation from medications, E.G. Anticholinergics like tolterodine, sympathomimetics, and decongestants, or other stimuli, E.G. Dim light. Risk factors, more common in women, especially age 40, Asian and Inuit populations, and individuals with farsightedness. C/F, rapid onset severe eye pain, halos around eye appear injected and pupils will be mid-dilated and poorly responsive to light, tearing and headache with N/V as intraocular pressure increases. Untreated acute AC can lead to severe and permanent vision loss within 2 to 5 hours of symptom onset. Optic neuritis, acute vision loss, pain, afferent pupillary defect, most commonly occurs in women age 50 and is often an initial presentation of multiple sclerosis. Optic neuritis is rarely associated with nausea/vomiting. Hearing loss. Presbycusis, progressive bilaterally symmetric and predominantly high-frequency sensorineural hearing loss that occurs over many years, affects 50% of adults 75 years. Pathogenesis, due to degenerative changes of inner ear or cochlear portion of 8th cranial nerve, C/F, usually hear well in 1 conversation in a quiet room but hearing significantly downward arrow ES with even small amount of competing noise. Subjective bilateral tinnitus can develop as the hearing loss progresses and is typically described as a steady or continuous ringing or rushing sound. Consider other diagnosis if U/L tinnitus, pulsatile tinnitus, or tinnitus associated with other U/L otologic features is present. Meniere disease, excessive accumulation of endolymph in the membranous labyrinth, is characterized by recurrent episodes of vertigo as well as unilateral oral fullness, tinnitus, and sensorineural hearing loss. Cholesteatoma, erosive and expansile growth consisting of keratinizing squamous epithelium, which can cause destruction of the bones of the middle ear, ossicles, and sensorineural structures of the inner ear, may have conductive and/or sensorineural hearing loss associated with intermittent ear discharge, tinnitus, and balance problems. Otoscopic examination typically shows a discrete white plaque on the tympanic membrane with or without perforation or retraction. Otosclerosis, development of sclerotic changes within the ossicles of the middle ear. Rightward arrow progressive conductive hearing loss with a normal otoscopic examination. Vertigo. Other causes, vestibular nerve impairment due to medications, E.G. Aminoglycosides, or tumor, E.G. Schwannoma, regional infections, E.G. Otitis media, labyrinthitis, benign paroxysmal positional vertigo, crystalline deposits, canaliths, in semi-circular canals. Rightward arrow disrupt normal flow of fluid in vestibular system. Rightward arrow contradictory signaling from corresponding canals on each side. Rightward arrow interpreted as spinning/vertigo sensation, Dix, Hall-Pike maneuver. Diagnose BPPV, vertigo and nystagmus are triggered as PT quickly lies back into supine position with head rotated 45 degrees, resolve spontaneously in most cases but can recur months or years later. RX, symptoms can be relieved by canalith repositioning maneuver, Epley maneuver. Aminoglycoside toxicity, aminoglycosides can cause ototoxicity, hearing loss, by damaging the cochlear cells. Some aminoglycosides, especially gentamicin, can also damage the motion, sensitive hair cells in the inner ear to cause selective vestibular injury, vestibulopathy, with or without significant ototoxicity. Because both vestibular end organs are equally affected, patients usually do not experience significant vertigo as there is no left or right imbalance in vestibular input to the central nervous system. Patients can experience oscillopsia, a sensation of objects moving around in the visual field when looking in any direction. This deficient vestibule, ocular reflex can lead to gait disturbances. An abnormal head thrust test can help detect vestibular dysfunction due to gentamicin. The patient is asked to look at a fixed target. Rapid head movement away from the target normally causes the eyes to remain fixed on the target. However, patients with vestibulopathy are unable to maintain their eyes on the target. The eyes move away and then return back to the target with a horizontal saccade. Patients with aminoglycoside toxicity occasionally have severe bilateral vestibulopathy, which can lead to chronic symptoms. Pain management. Patients with acute, severe pain should receive the same standard of pain management regardless of drug history, current or past opioid abuse. For morphine is appropriate treatment for acute, severe pain. Never undertreat pain, even if there is a risk of abuse, as it leads to dissatisfaction, longer hospital stay and higher risk of relapse. In the case of concern for abuse, frequent reassessment, outpatient follow-up, and referral to a pain specialist is appropriate. Brain death, irreversible cessation of brain activities. It is a clinical diagnosis. Criteria of brain death is not uniform in different countries, but common things are: evaluating cortical and brainstem functions, pupillary light reaction and oculovestibular reaction are absent, rightward arrow reflecting global brainstem unresponsiveness, proving irreversibility of brain activity loss, e.g. sufficient observation. Length, no hypothermia, etc. Spinal cord may still be functioning, therefore, DTRs may still be present. Isoelectric EEG may be used as confirmatory test, but is not absolutely necessary. An apnea test shows no spontaneous respiration at PCO2 values of 50 mmHg and more. Heart rate fails to accelerate after atropine injection because vagal control of the heart is lost. Hemorrhagic transformation. Patients with large or embolic ischemic strokes and those treated with thrombolytics are at high risk for hemorrhagic transformation. Usually occurs within 48 hours of the stroke and often manifests with deteriorating mental status. Diagnosis requires non-contrast CT scan of the head. QID, 12,214. Normal pressure hydrocephalus, NPH, path, decreased CSF absorption, triad of gait disturbance, dementia, and urinary incontinence. Wet, wacky, wobbly, slow, broad-based, shuffling gait. CT or MRI shows dilated ventricles. CSF opening pressure is normal. TX, serial LP, VP shunt, best. Contents: developmental milestones during toddlerhood.